Hello, everybody. My name is Min, and today I'm going to talk about cost and quality in hypertension care. First of all, let's talk about background study. Hypertension impacts 40% of adults globally, making cost-effective management essential for healthcare. While previous research on the relationship between cost and quality has yielded mixed result, primary care remains central to treating hypertension. Regional differences in healthcare spending highlight the importance of understanding the cost quality dynamics in primary care. This study seeks to examine the cost and outcomes associated with hypertension care. Next, we're going to talk about problem definition. The connection between hypertension care cost and outcomes is unclear, with few study focusing specifically on primary care setting. There's a need to identify factors that influence blood pressure control, and it is challenging to integrate cost data with clinical outcomes. This can lead to unnecessary spending without improving results. Balancing cost reduction with quality care is essential. This study aims to fill the gap in understanding hypertension management in primary care. Next is solution or intervention, and first one is study area. Primary care practices in Western New York State were the focus of the study on hypertension management in outpatient settings. The study examined processes such as prescribing, monitoring, and follow-up care. A total of 32 practices representing a mix of urban, suburban, and rural area participated with around 50,000 hypertensive patients included in the analysis. The study period spanned from April 2013 to March 2014. Next one is procedure steps. Blood pressure control data was obtained from practice EMR system, while claims data was sourced from two major insurance providers. Pricing was standardized using Medicare and other fee schedules, and claims were organized into episodes of care through ETG. Patients were linked to practices based on their visit pattern. The study calculated the average annual cost of hypertension care per practice and conducted a regression analysis to investigate the cost quality relationships. And next, measure the data, measures and data. The outcome measures was the rate of blood pressure control divided as less than 140 over 90 millimeter mercury, while the process measure was the annual hypertension care cost per patient, plus pressure data was gathered from EMRS and cost data was derived from claims, patient demographics, and comorbidity. Information was also collected. The analysis was conducted at the practice level, accounting for location using a generalized linear regression models to explore the correlation between cost and blood pressure control rates. Next one is data collection methods. Practices provided EMR data as aggregate accounts, while the identified claims data was sourced from a multi-payer database. Standardized pricings was applied to the claims data. Patients were assigned to practice based on their visit pattern, and hypertension-related costs were identified using the ETG rubric. Estimation method were used to address coverage gaps, and data validation was performed through geographic and demographic checks. Next one is importance. This study addresses a crucial knowledge gap in primary care and provided valuable insight into cost-effective strategies for managing hypertension. It challenges the common assumption that increased spending leads to better outcomes, offering guidance for policymakers and healthcare administrators. The research also highlights the potential to identify best practices, showcases innovative methods for integrating data sources, and contributes to the broader conversation on enhancing healthcare value. Strength and weakness. Strength of the study include a large sample size and a diverse range of practice settings, as well as the innovative integration of claims and EMR data. However, weaknesses include the limitation of aggregated blood pressure data, which restricts subgroup analysis and incomplete coverage of patients from urban practices. Challenges include potential variation in unmeasured patient characteristic and the possibility that practice level analysis might obscure obscure variation at the physician level. Additionally, focusing on a single geographic region may limit the study's generalizability. Next step and future work. To enhance the research, future studies should collect patient-level data for more detailed analysis and expand the geographic scope to include a wider variety of regions. It would be valuable to investigate the specific interventions employed by high-performing practices and conduct a longitudinal study to track trends over time, incorporating with provide incorporating patient-reported outcomes and satisfaction measure would provide additional insights, further exploration of how different payment method models impacts care quality is recommended, along with the development of predictive models to guide cost-effective hypertension management. And that is it. That is my presentation. Thank you for watching.